A man came to see me, 44 years old, sits down and says without any preamble, I noticed it got visibly smaller, especially at rest. I thought I was imagining it. Then my wife noticed too. This is one of those questions men sit on for years out of embarrassment, and they finally show up already armed with a pile of worst case scenarios pulled from the internet. Today I'm covering this honestly, from a physiological standpoint. What's actually happening to the tissue after 40, which part of it is just normal aging, which part needs a doctor's attention, and what can actually be slowed down or reversed. Clinical measurements show that average flaccid length genuinely decreases by roughly half an inch per decade after age 40. This is a documented age-related process, not something you're imagining. One important detail right away. This is specifically about flaccid length, not erect length. That distinction matters because the causes behind these two changes are partly different, and the level of concern should depend on which one actually changed. Let's start with the most common and most overlooked cause, the blood vessels. The corpus cavernosum, the spongy erectile tissue that fills with blood during an erection, accumulates collagen over time that replaces elastic fibers, a process doctors call cavernosal fibrosis. The more rigid collagen and the less elastic tissue there is, the less blood volume that spongy structure can hold even during a full erection, and the less full it appears at rest because the tissue is literally losing its ability to stretch the way it did at 25. This process doesn't happen in isolation. It's directly tied to the condition of blood vessels throughout the entire body. The penis is often called a cardiovascular barometer because its arteries, only 1 to 2 millimeters in diameter, are some of the smallest in the body, and atherosclerotic changes show up there 3 to 5 years earlier than in the coronary arteries of the heart. That means a visible decrease at rest is sometimes the earliest noticeable signal of a cardiovascular issue that hasn't shown up anywhere else yet, earlier than high blood pressure, earlier than chest pain, simply because these vessels are smaller and react first. The second factor, rarely connected to this topic directly, is declining testosterone. Testosterone maintains the density and tone of smooth muscle inside the erectile tissue, and as it drops, average levels decline roughly 1 to 2% per year after age 30, that muscle tissue partially atrophies, reducing baseline volume regardless of blood flow. This explains why two men of the same age with similar lifestyles can show drastically different visual changes. One simply lost more testosterone through natural variation, while the other maintained levels closer to youthful baseline due to genetics, weight, or lifestyle. Next is a factor that sounds almost too simple, but has a direct mechanical explanation. Excess fat tissue in the pubic area doesn't just visually cover part of the length, it physically pushes the base inward, and after losing even 11 to 15 pounds in that area, visible length often increases without any medical intervention at all, just from a reduced fat pad. This is the only cause on this list that's fully reversible through personal effort alone, with zero need for a specialist visit, just a change in body composition. Now to the question men are afraid to ask directly. Can this shrinking sometimes be a symptom of something more serious, not just age? Peyronie's disease involves fibrous plaque formation inside the tissue, and it comes with not just shortening, but also curvature during erection, and sometimes pain. It's specifically that combination of three signs that separates a disease process from the ordinary aging process, which happens without pain and without curvature. If the shrinking happens without pain and without any visible bend, that points toward a normal aging process. If pain during erection shows up or a new curve appears that wasn't there before, that's a reason for a urology evaluation, not a reason to draw your own conclusions. Now let's get into what can actually be done. And the data on effectiveness varies quite a bit here. Regular physical activity improves endothelial function, the blood vessel lining's ability to dilate, and in studies on middle-aged men, improvement in this specific marker correlated directly with improved erectile function, which directly affects how much blood that same tissue is able to hold. This isn't a generic exercise is good for you recommendation. It's a specific mechanism. Better functioning vessels mean more blood capable of filling the same spongy tissue, even if its structure has already partially changed with age. It's also worth addressing something that's often marketed as a fix, but isn't one: Vacuum pumps and stretching devices produce temporary results through tissue swelling or micro tears followed by healing, but controlled studies haven't shown lasting long-term length increase specifically at rest. The effect many people mistake for results typically fades within a few hours. This matters before spending money on a device that addresses the issue temporarily and cosmetically rather than the actual cause, whether that's vascular, hormonal, or fat-related. If the cause is specifically low testosterone, confirmed through blood work rather than assumed, there's a medical path that genuinely changes the picture. Testosterone replacement therapy, when a deficiency is confirmed by lab testing, restores smooth muscle tone in the erectile tissue over several months of treatment. But this decision only gets made after testing hormone levels, never on a hunch, because excess testosterone creates its own separate set of risks. This isn't something you pick up without evaluation. It's a therapy that requires medical supervision precisely because the normal range is fairly narrow, and exceeding it doesn't add benefit, only added risk to the heart and prostate. The man who came in with this question had blood work and a penile Doppler ultrasound done. His testosterone turned out normal, but his endothelial vascular function was reduced, which for his age became an early signal to get his entire cardiovascular system checked. His cardiologist found early-stage changes that would have otherwise gone unnoticed for years without this conversation. The first practical step is the same regardless of cause. Get a morning fasting testosterone test and talk to a doctor about vascular risk factors, because this is one of the few symptoms that often shows up before a person feels a problem anywhere else in the body. This isn't a reason to panic, and in most cases, it really is just a natural aging process. But ignoring it completely sometimes means missing the one early signal the body managed to send. Subscribe. I post breakdowns exactly like this every week, straightforward, without the awkwardness. Link in the description for questions you'd rather not ask out loud anywhere else.